Okay, well, we're going to go ahead and get started. I know many of you may be headed to other sessions, but if you are here for Ending Disparities, this would be the session that you would be in. I'm going to first start by introducing our panelists, and thank you all for joining us. I've had the opportunity to participate here with the National Minority Quality Forum for the past 3 years. My name is Shyrea Thompson. I'm the Senior Director of Strategic Initiatives at Susan G. Komen. In my role, I lead our health equity initiatives for the organization. I've also been honored to be a part of the 40 Under 40 inaugural class and really had the benefit to learn from so many of you in this room and really have enjoyed to date learning more about the work that our esteemed panelists have done and often in some of our communities getting to work with those that are seated here today. So I'm going to get started in introducing our panel, and then we're going to learn more about the work that they've done, the lessons they've learned, and the challenges they've faced, because I know each and every one of us each day are looking at how can we make more of an impact together. And this is certainly a panel to learn from. So I'm going to start here with Dr. Janet Franklin. She's the Executive Medical Director, Global Development at Amgen. Ms. Evelyn Gonzalez is the Senior Director, Health Communications and Community Engagement at the Fox Chase Cancer Center, co-chair of the Cultural Competency Committee, and a member of the Mid-Atlantic Regional Health Equity Council. Next, we have Dr. Karen Winkfield. She's the Associate Director for Cancer Health Equity, the Office of Cancer and Health Equity Comprehensive Cancer Center at Wake Forest Baptist Health. And then we have Ms. Lisa Sims Booth, who's the Senior Director of Patient and Public Engagement at the Biden Cancer Initiative. And then last but certainly not least, we have Ms. Andrea Ferris, the Chief Executive Officer of Longevity. So we'd like to thank each of our panelists for joining us. And today we're going to learn more about how we can work together to certainly end cancer, ending cancer disparities. Our conversation is going to explore policy, advocacy, and partnership efforts to really reduce cancer disparities across the United States to achieve health equity. Each of our panelists bring a number of years of experience, and we'd like to have each of them, starting with Dr. Franklin, share information about her background and the work that she does at Amgen. Dr. Franklin?
Thank you very much. I'm a global development director in our unit that actually looks at the advancement of clinical trials in the context of new and innovative therapies. So we have as our group a group that takes drugs that have already gone through the discovery science process, being tested in the laboratory, has already gone through the preclinical work that's done oftentimes in terms of new drugs and what might you find when it's once given to a patient, and then take it on from those steps when it's actually beyond the early stages of an investigation in patients or even volunteers without the disease. And then take it to the questions of what are the diseases this drug might have activity in, what are the diseases that this population, or what populations this drug should be tested in, and then how do you design a clinical trial to actually get those scientific questions answered. So that's my work here at Amgen, and of course in that context of being very much dedicated and interested in terms of clinical trials and getting scientific answers to advance healthcare in general, I'm of course interested in terms of making sure that the populations that we are studying are representative of those who might benefit from the medicine. And my career at Amgen is actually based on, or has a basis for the early work, the first part of my career, I should say, when I was an academician, and I was a pediatric hematologist and oncologist in active practice, treating patients, teaching medical students and fellows, and also being very active in clinical research in the cooperative group setting, the Children's Oncology Group. For pediatric cancer, as many of you may be aware, the 50 to 60 years of clinical trial work is where the great successes of advancement of pediatric cancer have come from. So there's a process there that I have as kind of my core in terms of clinical trials, means advancements for patients of all types.
Evelyn, would you like to share your perspective?
Yes, thank you. So I've been with Fox Chase Cancer Center now for 20 years, but I've been doing community outreach for a period of about 30 years. And throughout that time, I think I've learned more from the community than I've probably been able to impart with them. At Fox Chase, our efforts primarily to address the issue of cancer health disparities is both an internal and an external approach. So internally, part of the work that we're doing is to build build staff capacity. So cultural competence plays a really critical role in helping them how to understand how to work with diverse audiences and the importance of the inclusion of diverse audiences in clinical trials. It also marries up very nicely with some of the work that we're doing on the Mid-Atlantic Regional Health Equity Council, which is part of the Office of Minority Health. We have similar goals in addressing the cultural and linguistically appropriate standards. Additionally, we have a campaign called Be the Breakthrough prior to Genentech, and that's why you see these buttons, Ask Me About Clinical Trials, and our physicians wear ones that say, Ask Your Doctor About Clinical Trials, and it's a whole awareness campaign. Is it on? Can you hear me? Okay. It's a whole awareness campaign, so we have banners and posters, and the physicians wear buttons and flyers in the rooms, and what it has done is actually increase the awareness to facilitate discussion with the physicians. Externally, what we've done is, I'd like to take Donnie John's last comment. You've heard of the Riddler? The Riddler? Mm-hmm. I want to be known as the Rippler. Okay. That's what we do. We actually go out and partner with faith-based, community-based support groups, all community health workers, and we bring them into the field to really discuss what the issues are and to educate them. And I'll talk a little bit more throughout the panel about our community ambassador trainings, which what we've done in our first 6 months after training them is address that comfort level. What do they know, and how comfortable are they engaging others about the importance of research participation? And now we're getting ready to actually take it to that next level. So I hope to be able to discuss that as well.
Thank you. I've seen some of that work firsthand in Philadelphia and in the New Jersey area, so it's really interesting that you had that button on today. I was excited. I said, you've got to talk about that work. So Dr. Karen, would you like to share more about your perspective?
Well, thank you all for being here. One of the things that's very interesting to me is I don't think enough people are educated about how important a conversation around cancer is. Cancer is the #2 killer in the United States, and most people don't understand that very soon it's going to be the #1 killer. It's going to far outpace cardiovascular disease, and in fact, in many cities it already is. And so it's interesting. So Evelyn and I, I was told that we have a lot of similarities. I am a practicing radiation oncologist, so I also have a background in basic science. I'm a biochemist, so I have a PhD from Duke, and was really very fascinated in understanding some of the complexities around outcomes in cancer. So everyone sitting in this room knows that blacks have the highest incidence of the top 4 cancers and also have the highest mortality. And yet what was fascinating to me is I didn't see a whole lot of research kind of focused on understanding that while I was in my PhD training. And so it was interesting to me to say, well, are there molecular bases? We hear about biology versus some of the social determinants of health. What really is driving that? And here I was at several of different institutions and was trying to look at molecular differences and variances between different ethnic and cultural groups, and I could not get enough samples. Couldn't get enough biologic samples and specimens to do some of the research. And that started my thought process around, well, what's going on here? And come to find out, here I was training in Boston, Massachusetts, and found myself at some of the world premier cancer centers. And yet, when I looked around, the patient population, individuals who come into the cancer center, were not reflective of who was sitting right outside the door. And yet this was in Massachusetts, where we had Romney Care, right, long before we had Obamacare, and this issue of access really started to resonate for me. What does it mean to have access? Here we had some of the lowest uninsured rates in the entire nation, and yet there were individuals who did not feel that they could walk into the doors of the institution I worked at. So it started me on this mission to understand that access is not just about having an insurance card, that there's a lot more that goes into the challenges that we face with ameliorating cancer disparities and impacting cancer outcomes, that you must have a ground game if indeed you're to try to understand those complexities, because societies and communities have very long memories. And one of the things that I've really realized throughout my work is that sometimes institutions are very hesitant to accept their responsibilities into some of the disparities that we see. Remember, there are structural barriers to care, and many of them were propagated by the very institutions that are now knocking on the doors of some of the Black and brown communities saying, come, join this clinical trial, but yet they do not take personal responsibility for what they did, what those institutions did to create an environment that created many of the disparities that we see. So I made a transition from Boston down to North Carolina, and I've been at Wake Forest now for a year and a half. I am one of the associate directors of the Cancer Center. My focus is on improving cancer health equity. I also have the implementation arm of that, which is the Office of Cancer Health Equity, where our motto is that everyone should have the same opportunity to survive cancer and to survive it well. And to survive it well, right? Two different things, but we want to make sure that everyone has that capacity. And how do we do that? We do that by setting up programming. We do that by partnering with communities. We do that by understanding those communities, having a ground game. Because frankly, when you're at institutions, particularly those who are comprehensive cancer centers, and I can't just say everybody blanketly, but the majority of them, there are issues related to that institution that impact the community surrounding them. Eugenics was a big one at the institution I'm currently at. So how do we reverse that thought process in these communities of color? The only way to do that is to sit down with them, to talk with them, find out where people are. And that takes time and effort. And I must say, we need more resources. And so I'm so excited that the National Minority Equality Forum has set up this process here, where we can discuss some of the issues, where we can talk about who the stakeholders are and what we need in terms of both financial and human capital to really start to drive this conversation away from describing disparities. We've known that they've existed for decades. Let's stop talking about it and let's start making a difference.
Miss Lisa, would you like to share some more? I think Dr. Winkfield certainly charged us up, and we're excited to get into the meat of the conversation.
Oh, thanks, Karen. Yeah. Well, I won't be nearly that eloquent, I promise. No. Hello, everyone. So delighted to be here, and thanks for allowing us to join you today. It's important that we're talking about ending cancer, ending disparities, because that is the heart of the founding of the Biden Cancer Initiative. I want to share just briefly about the initiative, because I know there are a lot of questions. I think a lot of people are like, what happened after the moonshot? And yes, I do work with Uncle Joe. I'm just going to say that now, and it's an honor to do so. For those of you who don't know, the Biden Cancer Initiative was formed in July 2017 by Vice President Biden and Dr. Biden to continue the work that was started with the cancer moonshot. I mean, there was a lot of momentum from that effort, and they really wanted to stay in this work because they are personally completely committed. And the community said, don't leave. And they honored that call and formed BCI. And so really what we are trying to do is create, and with the help of others like the people here, the cancer system that we already think, most of you think already exists. You know, a system where the data that's shared can help lead to better treatment options because institutions can share broadly, where clinical trials are accessible to people, as we just talked about in the prior panel, and they're easy to access, and you don't have to drive 15,000 miles to get to the site. You can be in your own community, where patient navigators are available to every patient that needs to help them and their family through this incredibly taxing, scary journey. So we all think that already happens, and unfortunately it doesn't. But we know that through the efforts that started with the moonshot, with the efforts of things that are happening now, we can help continue that fight. There's a lot of great work being done already. Most of the folks here are already doing some of that work. And BCI we have an interesting role. I liken it to my mom, God rest her soul. She died of ovarian cancer several years ago, so I too understand this disease from that level. But she knew everything going on the street. When I would come home, she'd be like, well, Miss So-and-so, had this going on, and Mr. So-and-so, this is happening. Well, this is the role we see that we can play. We can be a connector. We can connect people, because what do we know? Great work is being done, but maybe you don't have the right partner. Maybe it needs to be amplified. Nobody knows about what you're doing. Maybe you want to start something new, but it'd be really helpful to know about some best practices that are already happening, so you don't have to fall in those same holes that others have created. We don't need to keep creating the same wheels. We want to play that role. We want to help connect dots, elevate work, and we don't want to start new programs. We're not trying to tread on anybody's territory. We want to help provoke partnerships, provoke new energy and enthusiasm, provoke people to think differently so we can help patients that are dealing with cancer, as Karen so eloquently put, not only they can survive it, but that they can live well, and hopefully, as we talk about, that we can end it, and that's the goal.
It's exciting. We know we need more accelerators in our community. So would you like to share your perspective? I know at Longevity there's a number of things, and when we were prepping, you were saying, I'm still learning as well, and I said, say that, because we are together. So I think for those that are newer to this work and really trying to find out, how does my organization play a role, this is certainly, I think, helpful to have your perspective.
Sure, thank you, and thank you for having me. As you said, I'm Andrea Ferris, CEO of Longevity Foundation. We are the nation's largest lung cancer-focused nonprofit. Something people might know, well, we have a beautiful map right here up on the screen of lung cancer incidence in the US, but actually 30% of cancer deaths are due to lung cancer. So it is a very, very large and very fatal cancer. And while the incidence is not exactly equal, but it's fairly comparable amongst whites and non-whites of the diagnosis of lung cancer, the mortality is significantly skewed. And I think that's what one of the things that we're here to address today is how do we address that, why is it, and how do we fix it? And so, this morning we heard a lot about democratization of information and meeting people where they are with information. At Longevity, we have 3 goals. One is to accelerate research, but research that patients care about. The second one is providing them with information understanding so that they can be active participants in their own healthcare journey. And then the third is to address barriers to access to that treatment. With respect to providing information, I think, we are a fairly young organization and growing, but our approach was the democratization, which was make sure that it's accessible on the internet. We provided information in all different forms, so you can get it via our app, via the internet, via print materials, via video. But even that assumes that you have a patient who is finding you. And so I think a lot of the democratization as well is to figure out how do we get it into their hands, and that it's something that is accessible to all different types of patients, whether it's cultural or at different levels of education or what that is. As we've evolved and as we've matured, and I think as other organizations and data has matured like this, we've been able to form partnerships, which is another thing that we've talked about a lot today in terms of how do we address this. One of the key things that we're participating with Jeannie in the National Minority Quality Forum, the Sustainable Healthy Communities. Fantastic, and I have to read it because I always forget the name. It's a really long name, Jeannie. The Diverse Cancer Communities Working Group, but there are several components of that are addressing with multi-stakeholders very key components to that. And it's fantastic work, and also just the zip code level data of where the people are so that we can start honing our messages in and our activities to address those communities at a very local level, I think can start to help. The other thing that we talked about this morning as well was underrepresented populations in clinical trials. To start working with that as well, and also just because it's the right thing to do. We're doing a lot of work with the Veterans Health Administration to ensure that veterans have access to clinical trials, both by facilitating standing up industry-sponsored trials in the VA, but more importantly, giving veterans access to trials outside of the VA as well, and smoothing that process out, which it's the right thing to do for the veterans, but also it will help address some of the disparities, I think, in clinical research as well. We are also working with partners. We're fielding a large patient preference study. It's modeled after what Parent Project Muscular Dystrophy did, working with FDA, but really to elicit what is it that patients want from their drugs, from the therapies that they're on, And we're working with partners to ensure that we can solicit that information from all communities, all patients, and do a comparison. Does it matter where you are geographically? Does it matter based on your race or ethnicity? Or, is it line of therapy that's the biggest difference? And working with industry partners, FDA, academics as well, to ensure that we're gathering data that has utility for that. So my hope is through all of these various endeavors, we can start to tease it out. And also just learning from sister organizations in terms of patient advocacy groups, they've become really sophisticated, and especially in the breast cancer space as well. And just learning what they have done to address some of these things and what's worked well. And I think the thing that was it shouldn't have been an aha, but it really is, you have to go hyper-local. It's not even by state, it's by neighborhood. And form those relationships at a very hyper-local to really get in there and make sustainable change. In lung cancer, we are at the forefront of precision medicine and at clinical trials. And so we have the benefit of that and a lot of activity, but really what we need to drive people to do in terms of taking action is take advantage of the preventative services, the screenings, to get your biomarker tested if you are diagnosed with lung cancer, and to learn about clinical trials.
That was a very strong opening, and I think you certainly spoke to the diversity on our panel today. And in your role at Amgen, Dr. Janet, you certainly are bridging the gap between public and private partnerships. Can you speak more to the work that Amgen is doing to really use that mechanism to address cancer disparities?
So Amgen as a biotech company, I think, truly has understood that you have to really have partnerships in this area because we don't have all the resources, we don't have all the information, we don't have all the skill sets. And so we've been about the process of trying to get an active education ongoing, not only internally, but also making sure that when we're doing partnerships, it's in areas that have benefit that we can realize in terms of clinical trials and the conversation around disparities. So for one, I think of three particular things to point out. So one would be just in terms of trying to understand what we can do as a company. And so one of the activities I think we're proud of is certainly being able to be here and being sponsors with many of the activities of this particular organization, because it's allowed us to get the education and the understanding of what things can we do to make sure that our clinical trials and our clinical research in general just has value in terms of populations of color in particular. The second item would be the issues around, I said, the kind of internal education, if you will. And we've done this over the last maybe 2-3 years or so, so a fairly new effort nevertheless, where we've had invited speakers to come in from different patient advocacy organizations to help us understand for the teams that are working on, say, a lung cancer trial or teams that are working on a leukemia trial, and get some more understanding about what are the needs of not just the general population, but specifically in terms of the minority populations that also suffer from the same disease. We've had conversations where we've had the past president of NMA come to our organization to speak with us. We've reached out and had distinguished faculty members from Morehouse School of Medicine and many others. So it is about getting that cultural awareness and competency within the organization. It can't be just one person, it has to be a group of people. And so that's one of the things we've also been doing in terms of exploring ways we might do partnerships in those areas around education and awareness. And then one particular outreach and public-private partnership that we're quite excited about is a more recent one, but nevertheless one that we have a lot of optimism about, and that's the Lazarex organization. It's a nonprofit organization that the Amgen Foundation has granted money to in terms of their outreach. And one of the things that they're looking at is, their particular strength, because we know there's many prongs to this problem, are the kind of underappreciated issues about the logistics. Because they have had a personal experience. The founders are three sisters that had a personal experience in terms of some of the challenges of knowing of a clinical trial in their case, but not being able to have, how do you make that leap to being able to access it? And so in the practical terms, when we think about not only the education and awareness to minority communities about clinical trials and what it could mean for their particular loved one or themselves, but it's about how, once I decide I'm interested, I want to do this, how do I make that happen? So this particular nonprofit has had an exploratory study that was first done with Mass General to kind of test out how feasible this was, and now is doing their pilot study called Impact. What the program does, or the project's designed to do, is a national program, and it's designed to provide resources, financial resources to patients to be able to participate in clinical trials. And it starts at the time when someone's trying to go there for screening and consent process. That's often the first hurdle. Can I get there? You know, if it's even in the same city, it could be just the issue of the extra bus fare, the taxi fare, what have you. The babysitter, the parking, because medical centers are known for notorious parking rates oftentimes, or having to get the validation that takes a long time to find and you're just frustrated. Little things that people have talked about, they're just so crucial. The meals, I'm eating away from home. I'm usually not doing that. I've got to worry about now the meals or meals for myself and my children or whomever else has accompanied me to the center to make this possible. So all those factors, and for someone who's traveling even farther than the airfare or the train fare or the lodging, things that just make it so that if you have the information, you have the awareness, you can make that final leap to be screened and potentially be enrolled in the trial. So those are the kinds of things that we're trying to partner with, and certainly, have really opened our minds about this whole conversation about what we could do with others who have the ground expertise to do this.
That's certainly a shift that we need, certainly thinking about the patient first. And Evelyn, in your role, you bring that perspective with more than 17 years of experience at Fox Chase. Can you share more about the successes and how you've engaged patients to really improve outcomes?
Absolutely. So, as I stated earlier, our approach is really internal as well as external. You can't just do one approach. You kind of have to address both. So one of the things we did early on was we did a program called SOURCE, which was strengthening our understanding of research through community engagement. Because just because we're a research institute doesn't mean we know all. The reality is if you don't engage people in that process, you're going to get a skewed view, your view, which may not be the best view or the only view. And so it's important that you include others in that particular discussion. And then we build on that. To Lisa's point, you don't have to reinvent the wheel. There are many evidence-based programs that are out there or strategies that have been proven effective. Yes, you might have to tweak them for your institution. However, they do exist. One of our current efforts is called our Community Ambassador Training, which is an evidence-based program that we actually adapted from ENACT. And it was designed for healthcare providers. We took it for lay audiences. So we had to simplify it, not dumb it down. Simplify it with clarity, give people resources that they could share with the community in plain language. One of the panelists earlier talked about the issue of health literacy, which I think is really, really critical. It does no good to do all this work, go to an institution, have a 30-page informed consent document written at a 19th grade level, and you haven't graduated high school. They're not going to sign it. They're intimidated by it. So if we don't begin to address these issues, as well as having boots on the ground to educate the community, that's an issue. So one of the other things we've done, which an earlier panelist stated, is you have to lay that groundwork down. So whenever we do education in the community about breast, colorectal, prostate, lung, skin, whatever, each one of those sessions has a component that addresses the importance of considering research participation, why it's important. And then we go into what a clinical trial is, as well as what are other ways you can participate, be it a biospecimen study or be it a behavioral study. And what we've learned over the years is that people, once you take the time to explain it in plain language and show them what their rights are, the right to withdraw for any reason at any time. Now, we encourage them what the backside of that is, because they have to know both sides, but they actually have comfort in that, knowing that just because they signed a consent form doesn't mean that I'm stuck here. So we've been able to learn a significant amount, and through our community ambassadors, what we found in just a 6-month period is that we increased their knowledge, we changed their attitudes. One of the pieces that was really interesting was whether or not to include The Immortal Life of Henrietta Lacks's book. We decided to do that, but what we found was 2 things. One was we wanted to prepare them in the event that they got asked any questions, that they weren't blindsided, but we had to take
it was a 6-week session. We actually had to add another week because they had processing issues. They were angry, and we needed to work through that before we could take that next step. But what we actually ended up doing was help them understand that as a result of these injustices that transpired, what are the mechanisms that we now have in place to address those issues? And they feel very comfortable and confident with that as well. So that was a big step for us. And so those are the kinds of things that we do, addressing clinical trials early on, helping them understand that when you're diagnosed, clinical trials should be part of that initial discussion when you're talking about treatment, not at the tail end, not when there's no other remedy or choice. You know, we have to change that paradigm. We have to help them understand that. And then also work with community physicians, because what we know, what the literature tells us, is that they participate when they're invited. So if you don't invite them to participate and you don't take the time to educate them, you're going to have minimal success.
So you shared a little bit about best practices, and Dr. Karen, in your work, I know there's a number of groups that you work with, including the work group that Andrea mentioned. Can you share some of the best practices that you've seen across the country at cancer centers? Because I think that's another perspective. Those institutions, as you mentioned, often have those biases and challenges. And what are the best practices to really getting at the heart of that matter?
So I think we're still trying to figure out what some of those best practices are. We've heard earlier that most of cancer care, probably 75 to 80% of cancer care, happens in the community setting. It doesn't happen at the large cancer or comprehensive cancer centers. And that in and of itself can be a little bit of a challenge in terms of clinical trials, in terms of access to treatment trials. And so that's one of the things that we're trying to figure out. So I do, in full disclosure, work with Sustainable Healthy Communities and the Diverse Cancer Communities group, along with Biden Cancer Initiative and ASCO. And actually I was part of the group that established the Lazarus MGH Cancer Care Equity Program. So there are lots of things that we don't know. Remember Jay Bott actually, as one of the first panels, talked about needing to understand where people go to get care. He mentioned in Washington State, for instance, that there were 5 hospitals that actually cared for about 50% of the African American community, right? 5. Mm-hmm. So if you want to impact and affect where care is given for Black communities, you would think you would start there. One of the challenges is we don't actually have our handle in terms of where cancer care happens, right? So we can see these nice color maps that are being created from the forum, but where are people going to actually get their cancer care? So one of the things that was very instrumental in terms of the Diverse Cancer Communities work group is we started asking where care is happening, where clinical trials are happening, and in particular, which institutions are doing a great job at enrolling diverse populations. So we found 7 institutions that actually had wonderful kind of participation of very diverse communities. Anywhere from 10 to 50% of clinical trial enrollees, cancer clinical trial enrollees, were from diverse backgrounds. And what we did was we asked them, what are you doing, right? We've got to do our job in terms of figuring out what is happening at those institutions. Why are they successful at enrolling diverse populations? Is it just because they just have the numbers coming through the door? Which is, that's a first barrier, right? So people have to come into the door. But then also trying to kind of tease out what are actually some of the best practices that they've implemented. We know that navigation plays an incredible role, but also partnering with community-based organizations. So one of the things, for instance, that we're doing at Wake Forest is we have cancer services that it doesn't matter from my perspective. I mean, there's always this thing, particularly at large institutions, if there's a competitor, for instance, that you want to be territorial. Look, there's enough work to go around. Right? So let's partner with the community-based organizations that actually can help to navigate patients regardless, so that patients have the ability to understand, that we can educate them about clinical trials, about care in general. And to your point, I have to say, Evelyn, one of the things that I'm trying to educate my oncology colleagues is that clinical trials shouldn't be, like you said, an afterthought. That's part of cancer care, right? We know that clinical trials, particularly for cancer, drives innovation. That's what drives the cure. If we're here talking about curing cancer, we have to get people engaged in clinical trials. And it's very different. And I think even primary care physicians aren't even aware of the differences and the nuances in terms of what happens with cancer clinical trials. And to that point, one of the things that came out of my work with the Lazarex MGH Cancer Care Equity Program, I was in charge of the community outreach and engagement piece, and I did a community-based study where we went and discussed with the community what are some of the perceptions of cancer clinical trials, what are some of the barriers, and fascinatingly, a lot of patients, particularly those who are treated at some of our federally qualified health centers and other centers, they say when they go to the cancer centers, they immediately go back to their primary care doctor, right? What do you think? And the primary care doctors are oftentimes left in the dark. There's a big black box. There's a lack of communication. And so it's really, the onus is on the oncologist to really make sure we're communicating so that patients aren't kind of left in a hole, in a vacuum, in terms of education and information. So I'm really excited. The wonderful thing is that this, the diverse cancer communities, that paper is going to be presented at ASCO. So there's going to be the abstract that came out of that work, where we've actually sat down and said, what are some of the best practices that are happening at your institution? You're doing such a great job enrolling. What are you doing? That abstract's going to be presented, so you'll be able to see that this summer. That'll be coming out. And then hopefully the paper will come out shortly thereafter. Because we need to, again, do our job at understanding what are the best practices and then disseminate that information to all of us around the table here, but also, more importantly, in the communities where people are getting their care.
It's really well put. So we know that the continuum is really key, right, to make sure that patients are having better outcomes. And Ms. Lisa, in your role, you again talked about those partnerships. Can you give us an example of what the Biden Institute is doing specifically to partner?
Absolutely. I think that my role as Senior Director for Patient and Public Engagement puts me in an opportunity to just talk to a lot of different people, and I've been there since August. And in that time, I have already done, just because I love to talk, so I'm talking to people, and then I can't tell I love to talk, but anyway. And all of a sudden I realized that this person doesn't know this person. And so I've already matched up a bunch of people that have led to some interesting opportunities. One, addressing some transportation needs, which we know is a huge barrier to getting to your appointments, getting to your clinical trials, getting to just treatment. And that's a huge barrier for people. And I matched up a young man who's got a new company doing transportation with a referral service that helps people do that in Massachusetts, which has led to them broadening their reach and things like that. So that's a one personal example of something that I've done. But I think that the BCI as a whole, we're looking for people doing great work who are partnering with other folks. The Diverse Working Communities is a great example of a moonshot initiative that National Minority Quality Forum took on as part of the moonshot, and we can see the fruits of that labor coming out now in terms of just being willing to take on that work, partnering with a bunch of different organizations. We're about to, I was gonna wait till the call to action, but I'll say it now. We're about to, I'll just repeat it so you'll remember. We're about to issue another call to action for partnerships, projects, things that are working that we're going to be then highlighting at our Biden Cancer Summit in September, which will be here in DC. But we really are, we are out there. I'm constantly looking, listening for those opportunities, as are my colleagues, of great work that's being done, and we're going to issue a formal call to find out about more of them, because we know that when people collaborate together, we saw the success through the moonshot of getting government, nonprofit, businesses, others to come together. I think we've seen examples both from the Amgen and from Fox Chase and the work that Karen's doing, as well as what you're doing, just partnering across sector. So we know that that's where the power is. We know that once we break down the silos that exist, and sadly they exist in our community, in the cancer work, they do, but more and more we can see that when we let down those, like, I'm only in this is my lane, I'm gonna stay here, when we can break through some of those, real change can happen and real impact can happen. So my day-to-day is to listen, learn, and try to connect who I can connect, but we need everyone else to be thinking the same, and then we're constantly looking for those opportunities.
So Lisa just spoke to breaking down those silos again so that we can learn and share. Andrea, how do you think that we can take the lessons that have been seen in lung and apply those to other diseases and cancers?
I think a lot of it is participating in things like this, participating in work groups and in other types of activities, as well as inviting people into work that you're doing. So with lung cancer, We use, a lot of our initiatives are to use lung cancer as a case study, not necessarily just to make it about lung cancer. So we do a lot of work with the FDA and EMA and European regulators to streamline clinical trials and make them more accessible to patients. Again, we invite other patient advocacy groups to be part of that, because I think anything that can be, because there is so much activity in lung cancer right now, that we sort of have an opportunity to use it as a good guinea pig, if you will, but that any other disease that's going down that path, we will help to clear some of those barriers. So with the recent CMS coverage decision on NGS testing, again, biomarker testing, lung cancer happens to be at the forefront of it, and the importance of doing multi-panel types of testing, hugely important because we run out of tissue. Any other disease that could benefit from that will just follow the path. So we're kind of clearing that and bringing people along. The other thing is, and it was alluded to earlier in terms of most of the treatment, it's not just lung cancer, it's most cancers is in the community. So we have partnerships with ACCC, which is the Association of Community Cancer Centers. We work with COA. We work with AONN, which now, that's the nurse navigators. They have a thoracic nurse navigator program that we work with them on, and also with ONS, because I do think that, particularly as we move away from academic centers, the nurses, nurse navigators, healthcare practitioners are hugely important in the delivery of healthcare. So we can educate patients, but I think that it's the whole system that needs to be educated in terms of the delivery of healthcare. Because if a patient goes and says to their doctor, I want to have my tumor tested, and they say, no, why? Go home, get your affairs in order. It's just, we're setting the patient up for failure. And, you know, it's just not a good scenario. So at Longevity and all the work we do, we try to work more in a systems approach, which includes bringing partner and sister organizations into that.
That was excellent. So as we shift to open up to Q&A, there are mics on either side of the room. I'm going to have each of the panelists, as Lisa mentioned, we were going to talk about the 3 things we can do when we leave here today. I had a chance to speak with one of the leaders of a pharma company recently, and she shared with me, you know, we've been admiring this problem for too long. And I think you all can say that we've gone to conference after conference and meeting after meeting. How are we moving into action? I think there's a wealth of information up here. So we're going to start, and if you have a question, please feel free to line up, and we'll just go from left to right. And those 3 action items, I know you already shared your one, that we can do when we leave here today to really reduce disparities and make sure that we're really achieving health equity. Dr. Price?
So I'll try to be quick. I mean, I think some of them are fairly obvious to this audience as opposed to an audience that doesn't think about this all the time. But one, I think the advocacy is important, because that really is how you make changes in the long term. You know, the multiple voices, the multiple expertises coming together as partners really make a difference. I think that's one call to action. I think the second call to action, and I think about my own personal experiences, both at Amgen, but also outside of Amgen, is that I think we need to take our passions and follow them throughout other parts of life. So volunteer, because there's so many nonprofits doing good work in this area, but they need volunteers. Everyone can't be paid. And so sometimes when you take your expertise and lend it in that setting, you're also multiplying some of the impact you can have in addition to what your primary day job might be. And the third, and I say this from my own background from pediatric oncology, is that I've always just wondered, have we always taken all of the lessons learned in pediatric hematology oncology and applied it to the broader adult populations where cancer is so much more prevalent? Because, in pediatrics, I was on panels many times when I was in academics where I was the only pediatric hemonc person there, everyone else was medical oncologists, and they wanted to understand how is it I got parents to have their patients enrolled on trials. We had great ethnic diversity in our trials, and yet these same parents, if they had cancer, were not either being aware or offered their trials, or they were not signing up for whatever the reasons were, whatever the dynamics were in those interactions. So I just had that conundrum that I still don't know the answer to fully, and I put that out as a challenge.
Excellent. Evelyn?
Okay, so one of the challenges that I have is, and I've been very fortunate to be doing what I do in community outreach for 30 years, but when the budget gets cut, guess who gets cut first?
Yes.
Okay? It's community outreach. Oftentimes, the other thing is, when a research study doesn't get funded and you get your little pink slip, guess what they're saying? You don't have enough ethnic minorities, or how are you addressing the issue of ethnic minorities? And they're like, what? So, though I just got an email last night saying, hey, we're working on this study, we need community outreach help to help us recruit this and this and that. Well, how come you didn't talk to me on the front end when there was some money involved? Okay, so they want things, they want our expertise, but it has to be reciprocal. So, that's a challenge. One of the things that we have done, and I would encourage you to do, is we've developed clinical trial synopses, where we take very complex protocols and we develop a 1 or 2 page sheet in plain language so that they actually have something to look at when they go home and say, is this a good choice for me? The second thing, which is something someone on another panel addressed, is the need to share those results back with community. We hear all the time, yeah, they come in here, they do their research, they write their paper, and we don't see them again. That's why community outreach is so important. We're in the community, we eat lunch in the community, we buy in the community, we do our hair in the community. We are a presence and we're committed to that community. So that's really important. Developing a plain language synopsis of, hey, this is what came out of that study, and oh yes, thank you for participating. Thank you. Because we found when we did our biospecimen study, we recruited 100 African Americans for a recent study, and 95% gave us a sample of either blood or saliva, and most were blood, because when we educated them that we could get more information out of blood for molecular, so for precision medicine, they were like, oh, absolutely. Because we shared those things. And then the last thing that I would say is training. And I don't mean just training externally with our, like I said, our community ambassadors or the community. You gotta train inside. You have to train those clinical research nurses, because not everybody has clinical trial navigators yet. So those are the things that I would say.
I always kept, when I'm doing my community work, I always leave the communities with my AAA. So this is Dr. Karen's AAA. The first is actually being aware. The second is ambassadorship. And then the third is advocacy. There are so many issues and so many barriers that can really bog down the system when it comes to cancer care. But we have an obligation to really become aware of those issues. So here we've had lots of different panelists, several sessions that talk about some of the barriers to healthcare in general. We know that our healthcare system is broken, but what we can do in this room is really become aware. Maybe pick 1 or 2 issues that you are going to become an expert in, right? So then you are aware, and then you can make sure that you then become an ambassador. Become an ambassador at your institution, that you are then going to say, okay, this is going to be my number 1 or number 2 issues that I'm going to go focus on. To your point, we need to make sure that everyone at an institution, for example, understands cultural competency. I don't like that word. I'm more about cultural humility, but since it's in the lingo, we're going to use it, right? So that includes the people at the front desk. That includes the first time somebody picks up a call. That includes what your website looks like. Is it representative and reflective, right? So becoming aware, become an expert, become an ambassador, and then advocacy. And we've heard it said earlier that what happens, we have to talk about the micro community level, what happens in the ground game. So advocacy, not just advocating on behalf of your patients, advocating on behalf of your community, but really thinking about advocacy in its kind of underlying sense in terms of the political arena, making sure that we are there getting people out to vote, right? Because what happens, and people always come out for the big presidential election, we need to be in that interim election. We need to be out there and casting our votes so that we can be advocates for our community. Thank you.
Lisa, did you want to share your 2 others?
Yes, I'll share my 2 others. Don't forget about the call to action, though. Okay, anyway.
Share best practices.
Best practices. 1, I would encourage you all, as you're here today and you meet and you're talking to different people, like, don't just say, wow, that's really cool what they're doing, but think about, is there something we could do together that would amplify the work that we're both doing? Could we be stronger together than we are individually? I think a lot of times we are also into what we're doing, that sometimes we miss an opportunity to be like, maybe we should partner, maybe we should talk about that more. So I know this group probably already does that, but just a reminder that it would be really great to think, how can we be stronger? Because together we can be more powerful. I would also encourage us to always think about and learning from people who've already done things. I go back to best practices. Like, there's already stuff that's concrete, proven, works. And so while we're out here like, I should start this again, I go back to let's elevate what already works and then let's use it. Like the people have already done it for us, so let's just use what we already know works, and then we can strengthen what we're already doing. So those are my two.
Thank you. Andrea? Well, that pretty much sums it up for me. No, so in terms of action items, because I agree, there are too many times where we just talk. One is really define the problem you're trying to solve. Solving healthcare disparities, it's like, curing cancer, mom, apple pie. It's just sort of, okay, how? So really pick the problem and then define it and define it well, identifying what's worked, and then finding the partners to help you get it done.
It's really well put. So I know there are some questions in the audience. I think we'll start here with this gentleman. Would you like to give your name and your question?
Sure. Good morning. My name is Dr. Derek Robinson, Vice President at Healthcare Service Corporation for Quality and Accreditation. Great panel. Given some of the racial and ethnic disparities that we see in prostate cancer mortality and the lack of very clear messaging regarding appropriate screening and the lack of attention in many quality measure sets that are tied to payment, what are your thoughts around how we might address some of the disparities that we see in prostate cancer and survivability?
Any thoughts?
I'm happy to take the question. So thank you for that. As most of you know, African American men have twice the incidence of prostate cancer than any other racial or ethnic group and die of it at 2.5 times the rate, right? So you would think that that would be a major call to action in terms of us kind of getting ourselves together and focusing on cancer health disparities. One of the challenges, as you clearly outlined, is that there's a problem in terms of there's a mixed messaging about the importance of screening. The United States Preventive Task Force has kind of said that really some of the screening shouldn't be done. What I always remind people is that the work that was done to inform that was not inclusive of African American men, right? And so, again, for those of us in this room to be aware and to tell our communities that does not apply to you. And not only do you need to get screened, but you need to get screened earlier if you're African American, right? So part of it is really about educating ourselves. Again, there's that awareness piece, and then becoming ambassadors, right? And then advocating. And so we've got to do that. And it is a challenge because sometimes the screening, the test, remember there's 2 parts of screening that can be done. Physical exam is still there and still needs to be done. The PSA test, there may be some issues because sometimes insurers will say, well, it's not something that we're supposed to be doing, so they won't cover it. But again, there's where the advocacy piece comes in, particularly for underserved communities and those who are really importantly and disproportionately affected by that. So one of the things that we used to do when I was working with the Farber at the Dana-Farber is we actually had a racially concordant patient navigator who sat there and had some informed decision-making conversations with patients. We know we have to do this for lung cancer, right? So that we're required actually to have some discussions around screening and shared decision-making. The same should apply when it comes to prostate cancer, but you cannot put that onus only on the physicians. This is where having a team of people is important, but there's where the cost comes in. It does take time, but sitting there having a racially concordant patient navigator sitting there and having a discussion, a shared decision-making conversation, so that before that patient goes in with their primary care decision to have a conversation about whether they need to have prostate cancer screening, they are well informed about the pros and cons of that.
Really well put. We'll take the question here.
Anka Askanase, I'm actually here with the Lupus Research Alliance, so we're crashing your party in a way, but I really feel like a kid in a candy store because the things you've achieved in cancer research are just fantastic, and I can only hope that this will come to autoimmune diseases someday. The patient navigators, the team approach. So we're here to learn from you. But 2 thoughts. I think we talked a lot about the consents and how can we do better. I think that most people that we want to have participated in research have never read 19 pages in one sitting. So how can we go back to a consent that says what it has to say in a concise way, and possibly an electronic version? And then the other thing is that negative memory is very powerful. Is there a way to enhance some of the positive memories and how to highlight the fact that doctors are a good force in the world and clinical research is a progress-driving institution? So anyway, maybe this is more just thoughts than true questions, but I struggle with this every day. Thank you.
I struggle with it every day too, so we're simpatico. What I can say is this is an ongoing discussion that has to occur institutionally. Whenever we get whenever we do research, we try to make sure that our informed consents are written at a appropriate level. However, when the legal department gets it, or the IRB gets it, or the physician whose PI perhaps study it is, and they want these words in there, it just jacks it back up. So a lot of times it's just a negotiation, a compromise of, okay, I'll use this word, but I have to define it, you know, those types of things. So it is an ongoing challenge and an ongoing discussion that needs to continue. You need to keep pushing the issue, you know, it may just be that this is that one issue that you decide to take on, the health literacy issues, trying to make sure that, you know, the information that you put out, be it on the website, be it on your informed consents, addresses those issues. So that's what I would say about that. And then the second thing is we've started to really record a lot of the testimonials, not only from the physicians, but from the patients, because I can talk to people till I'm blue in the face, as Lisa can. But it's more important for them to hear from people who have participated, who say, yeah, you know, I was afraid I was going to feel like a guinea pig until they got my meds right, and now I just feel really great. And so, but hearing it from them has more credence than hearing it from, you know, myself.
Well, that is a wonderful way to end, again, focusing on the patients, because this is why we are all here, to really end disparities. In closing, I'd like to thank the National Minority Equality Forum, and I'd also like to thank our panelists. I think they brought a lot of perspective to the work. And if you have questions, we will be here briefly afterwards, and we want to employ you again. Think about how you can act, whether that be through your advocacy, whether that be through ambassadorship, or whether that be through building partnerships. Thank you again, and we look forward to connecting for action.